Hello, good evening to everyone. Thank you for joining me for another session of Exploring the Science. This one is slightly outside of COVID, but the reason I was interested was because of something that happened in the research world. And straight away, as I noticed patterns, I usually want to explore them. And so this is about sudden infant death syndrome. And the backstory to this is that I had been in contact with one of the authors years ago, and I'd always meant to talk about this. And then I just kept on forgetting, or something else came up. And then there was a recent withdrawal of a paper about SIDS. And as soon as that came up, I thought to myself, you know what? I have got to get in contact with this doctor and find out what his thinking is because it may be very relevant with regards to the science. So, this is what we're doing. We are having a conversation. We're exploring his views on the science. I'm here to ask questions, not hard questions, but just to pull out and extract as much as I can. And it's a privilege whenever we have a researcher who is able to share their journey. I'll ask everyone, if you're with us, share where you're from. I usually share which parts of the world you are. It just helps people to know that this is a broad audience that we are listening with. So without further ado, I'll add Dr. Dov Gebien. Have I got that right, Dov?
Almost. Gebien, Dr. Dov Jordan Gebien.
Yeah, so Dov, you will introduce yourself to the audience and you will help us to understand a little bit about your background. So just tell us a little bit about yourself.
Okay, I'm a clinical doctor. I formerly trained and worked in the emergency room. I did residency in Grand Rapids, Michigan. I'm from Toronto, Canada. I came back to Canada and been practicing medicine here since 2009. So I have many years of emergency medicine background, and then I transitioned to just primary care, like working out in the community later on. And so I have a master's degree in pathology as well, which kind of is interesting, came into it inadvertently. So I'm not a researcher normally, but I had a little bit of training from McGill before I went to medical school in pathology of all things. Like I wanted to study disease. I was fascinated just to learn as much as I could. Actually, I'll just quickly throw in the reason why I became a doctor, I didn't realize at the time, was fear of not knowing what to do. I was in an emergency when I was very young and I didn't know what to do. And I think that later played in, but I didn't, that was not a conscious decision. But that's why later on I became an emergency room physician. That's why I studied pathology. And I wrote a master's degree and I learned how to write scientific, not proficiently, but learn how to write. And that really helped later on. So you never know. It's amazing how these things just kind of worked out later on. And so I work at a walk-in clinic, just happy to see patients and get to know people. And I found that the best joy is getting to know the patients, really. And it's a far cry from when I came out of residency. It's completely different.
So let me ask you a question then straight off. You
Yeah.
were in emergency medicine, and anyone who does that, I know, likes the action and the excitement of emergencies and accidents. What made
Yeah.
you transition out of that environment into where you are now?
Make a long story short, I got addicted to opioids right there. Bam. I
Wow.
have a long history of severe back pain since I was like young, like I was 17, 18. And it just got worse and worse. And eventually I got a taste of opioids. And it turned out I'm one of those people that enjoyed it like right away. And so it helped my pain, but it also melted away a lot of my anxiety. And slowly developed an addiction. And that just got out of control later on. Um, and I just crashed and burned in a shorter period of time. I transitioned from a pill opioid to a more stronger opioid and just fell apart. I lost a lot
Wow.
in the end. I lost a lot, and it was very humbling. And I made it through it. I paid dearly for. They're not mistakes, you know. Like I learned, I learned a lot about mental illness, inadequate coping with stress, adverse childhood experiences, learning to take accountability, responsibility for my decisions, and how the most important things that I learned were when I had nothing was hope and other people. And I made it through it intact. despite some pretty horrible things. Which I mean, I'll just let you know right now. I did 18 days in jail and 8 months in prison for abusing my prescribing privileges. Fortunately, nobody was hurt. My family got hurt the most, really. My young children and now ex-wife moved out of Ontario, Canada, to another province. I lost a lot, but in the end, somehow I made it through it. And it turned out that struggling and going through so much like that, losing my freedom. Oh, I just want to say the reason why I was incarcerated, uh, I was inappropriately prescribing, and they considered that trafficking, even though it's not trafficking to sell. I wouldn't have a medical license now if it was to sell. But anyway, it was to feed my addiction, an out of control addiction at the time, and it's considered a medical illness, not a moral failing. That's really important to understand. It's too easy to judge people. Okay? Deeper, it's too simple to look down at people. Don't judge them. Find out what's going on, because there's usually a lot more adverse childhood experiences, for one, in ways that people just learn what they just want to melt. They want to melt their problems away, and in the end, I paid dearly. But the best story is that it remained intact, and I became a more loving person, really, in short, a better person, um, just humbled. And what a lesson it was. So I've learned that those who are suffering around us, those are the most fascinating people, and to listen to people. Online, it's so easy to cast judgment on others, and it's unacceptable. We don't know what's going on in others. It's so easy to become full of hatred, even. Like, we don't know the full story, so reserve judgment. Try.
You listen,
Yeah,
straight
listen.
away, as I said, I did not know this story beforehand. And as
Mm.
soon as you started to speak here, I thought to
Oh no.
be this open in terms of sharing their experience. I mean, that is an absolute credit to you, one, and being able to say that. I am definitely capturing that because I think a lot of people need to see that. One, own your mistakes,
Yes,
recognize the fallibility, and understand the statement, there goes I, but for the grace of God. So that is
absolute
really, really powerful. And it
brutal
sets,
honesty.
yeah, it sets the stage for why you probably have the insights that you do. So what I want to understand now, because what we're talking about is SIDS, and I guess
Yeah.
I'm curious to understand what in the world triggered your interest in SIDS. What's the emergency department? Was it a personal experience? What was it?
Yeah. So I had a fascinating case, and actually, it's a colleague, medical doctor, um, and he told me a chilling story of what happened to him starting at 8 years old, 7 or 8 years old. Somebody I saw through the walking clinic, and I knew something was. I mean, I honed my skills as a diagnostician, working all those years, working in the emergency room, the pathology background, whatever. But the story was very concerning, and it doesn't take a special anybody with common sense, if you listen, would realize there's something chilling about it. But I mean, yeah, his story was starting at 8 years old. One night, he woke up in bed. As he woke up, he felt the first thing is his mouth opened spontaneously like a fish out of water, and that was the first thing that disturbed him. He was, why is my mouth doing this? He woke up very quickly. Well, not quickly, but just it caught his attention. His mouth moved against his will. He closed his mouth, and then it did it again. It opened up on his own, and he was gasping. He was trying to take a breath in. He didn't. That was the next thing. He tried to take a breath in, and absolutely no air was coming into his chest. Um, he was in pain that he'd never felt before in his ribs. In fact, he thought he had been picked up by his big brother. He's still in a waking state here in a matter of seconds. He thought his big brother had picked him up in a bear hug. He knew what the pain felt like, of that pain of somebody holding you up, and you can't open expand your chest, and it's rib pain on both sides. And he described it as a cramp. Um, he's 8 years old, and he knew he was in deep trouble. He tried to breathe in harder, and it was met with complete resistance to airflow. In fact, he said, that's when I learned what the meaning of futility was. So he knew he was in dire straits, and he knew he was about to die. And oh, by the way, I'll just leave that part out. So the bear hug, he turned around in bed. He turned around thinking his brother was holding him. And he turned around and realized he was in bed. Like, it's such a weird story, but that gives it the truth to it. This kid was able to troubleshoot under pressure, knowing that he cannot breathe in and he was about to die. And he said, try something new, because breathing in did not work at all, a complete inspiratory arrest. And so he experimented. As I said, he tried to breathe it harder. That didn't work. And then he said, well, to himself, try breathing out. And that was the biggest gamble of his life, because he knew that if he breathed out, that he would die quicker. And he did it anyway. And this is such a crazy story. And it worked, obviously, because immediately the bear hug, cramp pain, and inspiratory arrest completely went away in a flash. And he survived it. And this kid was like, wow, I almost died. And he goes back to sleep. And this is not the first time. This has happened in the night periodically. He doesn't know how many times, but countless. And he went through it many, many times. But after the first time, he knew what the solution was, and he survived it. He said it happened between ages 8 and 17. And he basically, I guess, forgot about it. It was, I guess, traumatizing for him. And he didn't talk
And
about it
what
for
made
many
him
years.
tell you about it at that time?
That's more complicated, but something happened in his life that it finally came to light. It's weird how the sleeping life, the night life of sleeping, seems so separate, and things happen in the night that people are like, don't talk about it sometimes. There's a lot of, in my research, I found a lot of people have a lot of things to say about, oh yeah, I remember waking up and I felt like a restriction in my ribs. So as I'm talking to people, a lot of people have stories about this, but it just doesn't come to light for some reason. So I'm hoping this conversation will do that. And lo and behold, I mean, obstructive sleep apnea is very common, underdiagnosed. And there's lots of stories of people like waking up in a panic with near death panic, and but different from this story. This kid, if he had not figured out the solution, okay, he would have died right there and then. He was 8 years old, so he was not an infant, but it was clear that this could be a mechanism of sudden infant death syndrome. But he was
Wait. So you've gone too far there. When you heard that story, how did you connect it? Because you're right, other people have said this. I've heard people talking about this myself, where they couldn't quite get their breath in their night. They felt as though they couldn't breathe. But I never connected that to sudden infant death. So this is what I'm trying to see if I can unpick from your brain. How did you get to that?
In the beginning, first of all, I had a very little knowledge about sudden infant death syndrome, and the diagnosis here, because he was older than 1 year, would have been sudden death in the young, or sudden unexpected death in childhood, SUDC. So I didn't know much about it at the time, but just thinking it through logically, I mean, had he died, the diagnosis after autopsy, as long as they didn't see any cardiac anomalies or anything out of the ordinary, it would have been ruled a generic diagnosis, like a unknown, but just like sudden infant death syndrome. The proper term for it right now is sudden unexpected death in infants. Just it's better to call it SUDI, SUDI. But anyway, what's my train of thought? An autopsy, if nothing else came up, it would have been classed as a sudden unexpected death in the young, which is no different than sudden infant death syndrome. It's a mystery. There's no explanation at autopsy. So now my research is coming in as I learn more.
I want to pause you here a minute. Because you have just opened something that I had not thought of.
Okay.
In the post-COVID period here, a lot of people have been talking about sudden deaths, okay? It's one thing to have somebody fall and collapse on a football field or running or something. But we have been seeing patients who go to sleep and don't wake up. My presumption has always been that this is likely to be a cardiac arrhythmia, that they have had some kind of rhythm disturbance because there's no pathological. Do you think it is possible that this pattern could explain this unusual phenomenon that people are talking about at present?
Yes, I believe firmly, after my research, we're talking 3.5 years of tons of research in my spare time. But what is it about sleep? What is it about sleep that causes deaths? Cardiac happens. Cardiac can happen at any time of the day, but like it doesn't explain it. So what the answer is yes. I believe my that primary respiratory arrests are happening in the night, and the question is, and the cardiac is secondary. That can't be proven at autopsy, but just to consider the possibility that these are respiratory arrests primarily. That makes a lot more sense. And the question is, why are respiratory arrests more common at night? And the answer is fascinating. REM sleep. REM sleep. And now, rapid eye movement sleep is a stage that's deep. And when the central nervous system shuts down all skeletal muscles, when we're dreaming, so we don't act out our dreams, over many years of evolution, if our muscles are working and we act out our dreams, we will fall out of the tree and we will die. For example, I mean, it's we cannot. The body gets shut down. The muscles of the body get shut down during REM sleep, and we all know this. If you look at a sleeping dog, they're muffled barking, they're kind of muted movements of their paws. But what happens? What happens in REM sleep? What happens to the respiratory muscles? Because it turns out they're also skeletal muscles. There's the respiratory pump muscles, which is the diaphragm, but also the accessory respiratory muscles, which are in the rib cage, between the ribs, intercostal muscles. Now, this patient zero, that's the name of the patient I had. I didn't say that before. He described bear hug rib pain, cramping of the ribs. And so during REM, this gets a little confusing, but during REM sleep, the accessory muscles of breathing shut down. That's known. There's papers, lots of papers showing that. So if you shut down the accessory muscles during REM sleep and you have a fatigued diaphragm, and now you just put a workload onto the diaphragm, you can put it into overload. And what happens to fatigued muscles? As we all know, they can become cramp prone. And I mean, the patient zero said it himself, cramp, diaphragm. He had both sets of respiratory muscles must have failed for him to have complete inspiratory arrest. That means the intercostals failed, and I believe from REM sleep, and that put an extra workload on his diaphragm, and that went into failure too. And that is the best hypothesis I have. So long story short, to summarize that, yes, respiratory arrests are just as possible during sleep. Just to be um, conservative, respiratory arrests are just as possible during sleep as our cardiac arrests. In fact, cardiac arrests, what makes them special? Why would they happen during sleep? Because of bad dreams, a hyperadrenal system. Doesn't make sense. But I think the REM sleep hypothesis has some weight to it, as I've learned.
Wait, let me push on this one here, because I can imagine if a clinician is watching this. We see these patients go into left ventricular failure 4 o'clock to 6 o'clock in the morning with a cortisol surge. So they could argue that, yeah, cardiac events do occur in the night. And so you could have something like that. But you are right. They would be unlikely to just go into an arrhythmia where they have no background of cardiac disease. And
Aha.
so this is the bit that why I think that what you're saying is really, really interesting. Now, my question would be, in the same way that this guy had multiple episodes of this, I can't imagine that this would just happen as a one-off episode. I am imagining that this must be going on and people are not recognizing the significance of it, and then they have a severe episode. Is that more reasonable?
Sorry, that's a good question. What happened to him probably happens to a lot more. In fact, what I think is many, many deaths occur this way, and it's been missed all this time. But why haven't we heard about this from other people? And the answer, I believe, is that sadly, he was 8 years old and was plastic mind, plastic body, and he didn't panic. An adult, if they woke up in that, would panic. And I think my firm belief is that He is the exceptional survivor from this. First of all, combined failure of both respiratory muscles doesn't happen that often. It happens in those who are vulnerable, and that's basically the young, the very young. Why does this happen more in babies? Well, why is this more common in babies than older kids? Because sudden infant death syndrome is much more common than sudden unexpected death in children, older children. And the difference is immature respiratory muscles. The youngest of infants have incompletely developed respiratory muscles, which are fatigue prone. Much more. And as we get older, our accessory muscles, the ones in the ribs, the intercostal muscles, become trained and get stronger, but not in early life. So that explains why it's the young. Explain why it's at nighttime. Why it's not common across the population. As we get as the person gets older, is much less common unless there's something causing weakness of the respiratory muscles. And this brings me, I don't know if you want to make the transition, to damage, myositis of muscles.
Like wait, before you go to this, I want to make sure the audience understands what you're saying, because a lot of people are hearing what you say, but they can't picture. They don't even know what the diaphragm is. So in preparation, I got an image here, and I'm going to show you just generally. Oops, sorry, I have to add it to the stage. Here is the image that I've done. Normally, when people breathe, the main thing that causes their lungs to expand is this muscle here called the diaphragm. It separates the thorax from the abdomen. And when it contracts and pulls down, it pulls air into the lungs. Now, most people, if, for instance, they got asthma and they had air trapping, they can then use chest muscles to help them to breathe. Or if you're very tired, you can then use the other chest muscles to help you breathe. But if you are just breathing normally, you will notice your chest is not moving. And the reason is because your diaphragm here is contracting. Now, what you are saying is that in some children, or even potentially some adults, this then goes into spasm, and they can't then take a breath. So they can't pull air down, they can't expand their thorax. And if you are not awake to be able to do chest breathing, for people who sing, when they tell them to breathe through your abdominal breathing versus chest breathing, you can get stuck in this phase, not being able to inhale. And this is effectively what you are saying happens to infants. And this is why they are unable to do the transition to chest or exhale, as you're saying, and therefore they go into respiratory arrest. Is that about right?
There's a lot of steps involved there.
Yeah. Okay. All right. So let's now go. Let's go into the steps. I just wanted people to understand the basics about where the diaphragm is and how it works. So let's explain now what you're saying.
Yeah. See, all of this can be explained. Okay. It doesn't take anybody with extra education. You know, it's just, and it's intuitive too. We all know what a cramp feels like, and the muscle can flicker before it goes into a full cramp. And what leads to, I mean, what causes cramps in the first place is muscle fatigue, other things too. But the step, I missed one of them. Okay, so something can weaken the respiratory muscles of various causes. Okay, when a muscle gets fatigued, it becomes cramp prone. Okay, I say cramp, but there's also the flickering. There's various types of, it's called excitation. Okay, like abnormal contractions of the muscle. So when it's fatigued and a sudden workload is added to it, you can precipitate or cause excitation. And that excitation can be flickering, they're also called fasciculations. They can go into a brief spasm. They can go into trains of spasms, which is like there's a hiccup, for example, is a diaphragm spasm. It's a single spasm with the closure up here. So there's a whole spectrum of different versions of excitation. So fasciculations, spasms, trains of spasms, which are several. And then there's, believe it or not, there's diaphragm flutter. That's a known thing. It's a rhythmic type abnormality, and there's plenty of papers on that. And then there's The one that I think happened in patient 0 is a sustained contraction, like tetany, like you put your finger in the socket and the muscle doesn't let go. That's the cramp of diaphragm cramp. So to make a long story short, um, most of these don't cause serious symptoms, and in fact, diaphragm spasms can cause a whole plethora, a whole variety of symptoms, um, and a lot of them are not life threatening. But in some people, it's a sustained spasm, the cramp or tetany. Now that can become that would go from, okay, there's apnea, which is lack of breathing, which is what happened in patient 0 and happens in babies, premature babies all the time. Apnea, but now if it's sustained, it becomes, we call it respiratory arrest, but it's basically the same thing. So I hope I covered it there. I may not have done a great
Yeah, I
job.
think I understand. And so, summarizing it for the audience, because I'm hearing this for the first time as well, is that different kinds of muscular movements, in this case, when it comes to SIDS, instead of it just being a single contraction like a hiccup, it is a sustained contraction of the diaphragm, which locks it into position. And
Yes.
if you imagine that this happens even on expiration, so because in theory it can happen at any time, if it's inspiration or expiration, can you imagine if that is locked in expiration and you can't even blow out air any further? That is potentially very frightening. Now, I want you to help people to understand something, because you must have applied thought to this. Because a lot of people will be now thinking in their mind, oh my goodness, I remember waking up in the night and I couldn't move and I couldn't breathe and I felt as though
something on my chest.
Exactly. Something is on my chest. I have heard that on multiple occasions. Yeah. Is that the same thing?
It's, there's incubus, succubus as well. There's some crazy stuff there, but let's start with the medicine here. With the medicine, it's people people waking up, sleep paralysis. Okay, some people wake up when they're in REM sleep. I spoke before about the muscles of the body being shut down, like we're paralyzed basically, and 99% of us don't wake up during it, and we're in a sleep. But some people reach the waking state, but they're locked into their body, and that is scary as hell when that happens to people. And at the same time, remember now their accessory muscles of breathing have been shut down, so they feel short of breath, and sometimes they describe it as like a pressure on their chest. And I went a little far there, but other people from historical accounts, anyway, I'm not going to even go there. But it's the highest risk period of our lives, hands down, of the day. Okay, it happens every day. It's the highest risk period of dying, as far as I'm concerned, because we lose the helper, the accessories to our main muscle of respiration. So sleep paralysis is just one of them. It's incredibly scary for people. Sleep apnea has many more apneic spells during REM sleep. No surprise there, right? Because that's when the accessory muscles shut down. There are more deaths during that part of sleep. I believe. I have to confirm that. Don't want to speak untruths here. And so it's fascinating what happens at our most vulnerable time of the day. And babies that sleep most of their lives are at the highest risk because of sleeping and going into active sleep. It's called active. They don't call it REM sleep in babies. Sleeping babies, they call it active sleep. It's that's just, there's other things that happen. Sleep paralysis is one of them, but the point is when the accessory muscles of breathing get shut down, and that's when havoc can happen.
What I want to do here, because a lot of people, again, may not have heard about in a sense, the thinking behind SIDS, sudden infant death syndrome. And so I'm sharing here your paper. And this is the 2024 one, metabolic acidosis and sudden infant death. And what I want to focus on here is when you are talking about all of the risk factors This is a
Yeah.
lot of risk factors: prematurity, male sex, higher parity, low birth weight, smoking maternally, environmental check. This is like a whole chain of things.
Yeah.
How how does this fit with regards to this concept of diaphragmatic spasm? Why would all of these things be an increased risk? Have you got any thoughts on that?
Yeah. We're talking about diaphragm fatigue factors. What can fatigue the diaphragm? And when you look at that and compare it to the SIDS risk factors, there is a massive amount of overlap. What causes muscle cramps? So again, I know I'm biased because I'm coming from a certain angle, but when you research what fatigues the diaphragm, uh, there's there's no question there's much overlap. So that list there in one of my papers, a separate paper, I did look at some of the risk factors. So I could go into so much detail here, but I don't want to. But too much. But males, why are males at higher risk? Weaker respiratory muscles. There's plenty of papers showing that. It's not well accepted yet, but it's obvious when you put them all together that male, especially babies, have weaker respiratory muscles. In SIDS, there's a higher death rate amongst males. I think also in post-vaccine sudden deaths in children, there's more males that are dying. So the answer from my angle, it says because they have more fatigable diaphragms. Another important one you wrote up there that's in there is younger age. Okay, that's I talked about that already. Prematurity, is it in there? Yeah, prematurity. Because they have less developed respiratory muscles. I talked about that earlier. That's a fatiguing factor. They can become fatigued more easily. The other one, though, I came across this in my research. Like, as I said, I'm not a researcher normally. Okay, I come from an emergency medicine background, but it's just a nice, fresh take on things. Nicotine. That's a well-known, cigarette smoke exposure in the house. That's the actual proper way to define that risk factor for sudden infant death syndrome. What is it about cigarette smoke that can predispose a child to dying? And this shocked me that when I looked up nicotine, just the most common ingredient in cigarettes, of course, is nicotine. Well, as an emergency medicine doctor, I looked up the toxicity of nicotine. What happens in nicotine deaths? And lo and behold, respiratory muscle paralysis. It, it just blew me away and it pissed me off because it was right there, right in front of us. You know, it's funny because I'm a doctor as well, so I need to say we. I take part of the responsibility, but we knew the risk factors. Why didn't anybody explore common sense and look into the risk factor, nicotine? What happens in overdose? And it was right there. The answer was right there. Respiratory muscle spasms, rigidity, and paralysis. And there's plenty of reports. In my paper, I quoted I think it was 1935 paper, which is an excellent paper. And the author said, to their expert opinions, from what they researched in animals and studying the case reports with young children who ingested small amounts of nicotine by mouth, that's another thing. Very dangerous for anybody who has vape products in the house. If ingesting nicotine is incredibly dangerous for children. I mean, just in the smoke is bad enough for young babies. So just to know that it's incredibly toxic. Small amounts in their reports, these kids took small amounts and they were dead within 15 minutes to half an hour. And they said it was from failure and paralysis of the respiratory muscles. Now, if you compare that to the SIDS body or even sleep apnea things, they consider causes of respiratory arrest to be from the brain not giving signals, which I question sometimes, and it may not be all the case, or obstructive sleep apnea. Okay, obstructive where there's like closure of the airway. But what happens in nicotine is a third mechanism, that it's failure of the respiratory muscles by going at the respiratory muscles themselves. And that's the new thing that has been there, but it didn't come to light by anybody until I came across it. And that's why I said it pissed me off, because it was there. It was right there the whole time. And how was it missed? With all this research poured into SIDS, how was this missed? The simple thing, there was the clue, smoking gun right there.
So when we look at this, so this is the consensus view about SIDS. They think, is this consensus? That's your paper, but I mean,
But yeah,
So is this your extrapolation rather than consensus? Because in the paper you pointed that there are three things that they consider
yeah,
within the framework, and
right.
but this is your extrapolation.
Yeah, the third line down, starting with, but it's best to go start on the right side. CNS dyshomeostasis. So that's
Yeah.
saying there's three ways for people to die, or babies to die, like from the lack of signals, or it can come from the cardiac causes, or it can come from respiratory causes. But we've simplified it here, saying we've gone right to the failure at the diaphragm muscle itself. Okay, so we're missing. Actually, never mind. Yeah, so that's the consensus. It's a basic overall look at it, and it's actually quite comprehensive. That the diagram. Sorry, I got a little complicated there.
Yeah, so
It,
the main point here is that because when you've looked at this, and I know the feeling as to when you've seen something that you think is really important, how has the scientific community responded to your theory, the idea about this spasm? Are they open to it, or is this going to be another case Helicobacter?
what was the name of the doctor? Semmelweis? Semmelweis.
Yeah, yeah, seven-wise.
Semmelweis reflex. I learned that from a YouTube channel. I wish I knew his name. John something. John Campbell. Excellent channel. Um, the Semmelweis reflex is basically, and I've seen this. My answer to that question is, I want to be nice about this, but the overwhelming, I can't believe the amount of resistance. No matter what, if you push, if you present the average, no, if you present a physician, another person or a clinician or a researcher with compelling evidence, there's this ugliness of human nature to just turn their head and refute it right off the bat, ignore it completely. It's despicable. And I have done so much outreach. It's upsetting just for me to talk about. Like, I have reached out to a tremendous extent, and it is shocking, the resistance, the reluctance to the way to be in professionalism as a physician is, hey, thanks for bringing this to my attention. I'll check it out. It sounds interesting. I appreciate it. Instead, I don't want to get too negative here, but the overwhelming response is no response. But I know I got the right contact. The overwhelming was, sometimes they say thank you, but I know better. That's what it is. It's like, who are you to come out of the woodwork and teach me something? Don't you know who I am? This is the other side of me coming out right now, because don't forget, I'm in recovery. I lost everything and regained it. And what I see in the medical profession, and this ugly side of the higher the position, I know, I'm sorry to say it, but in general, in my outreach experience over 3.5 years now, the higher the experience, the higher the position, the more reluctant that person is, and they're failing their patients and they're failing their job, and it's an imposter syndrome. Really, I'm extremely upset about that.
Well, I think
And
that truthfully,
there's good news though.
yeah, I think that truthfully, we saw this with COVID, and we saw
Yeah,
this throughout the pandemic.
same
With
ugliness.
regards to,
Yes.
yeah, it's a similar kind of thing where people who came up with ideas, who were trying to find solutions, technically became the bad guy.
Yeah, it's not supposed to be, hey, thanks for the hypothesis. I'm going to check into it. That's the way to be. What the hell has
Yeah, I
happened to
mean,
people?
why would somebody discredit the fact that you have spent years thinking about this, researching it, writing papers on it? Now, even if they disagree with you, it's not about whether or not they agree or disagree with you. It's about the fact that common courtesy is to say, actually,
Yeah,
I'm very happy you are doing this kind of work, and I'd want to encourage you to continue. I don't necessarily agree with everything
yeah,
you're saying,
yeah,
but I will give you the courtesy to at least look at it and give you some thoughts about what it
yeah.
may be.
What you just described was Dr. Paul Goldwater. I reached out to him out of the blue, and he was exactly that. And I'm so grateful to him for that. That's the professional way. Yes.
So now you've mentioned Dr. Paul Goldwater. Now there is an important thing, because he's in Australia, isn't he?
Yes, and he's a SIDS
Yeah.
researcher.
So he's a SIDS researcher. So he's one of
Not
the
research
few.
lab.
Yeah, so he's one of the few who actually listened to you, and you guys published that paper together.
Yeah.
Now, here is an important thing, because he seems to be taking the fight to the scientific community, and they don't like it, because I had mentioned that this paper here that he recently published, Sudden
Mm,
Infant Death Syndrome, a
yeah.
review and reevaluation of vaccination risk. Now, listen, the minute you touch this, you are touching a beast. Okay?
Yeah. Yep.
Did
Sensitive
you?
subject.
It's a very sensitive subject. And this was, so just so that people get the context here, the reason that I remembered about this, as I said, I'd spoken to you some years, or contacted you some years ago, when I saw this paper, this come up, and it was so weird. This paper was published in 2021. Then suddenly now, this paper had to be removed. So the
Wait.
editors.
Which paper? Oh, this is a different paper now.
So this
Just
one,
pointing that out. This
Vaccines
is
and
the
Sudden
Miller
Death, an
paper.
analysis of the
Right.
VAERS database. So
Yeah.
this paper now gets removed because they said there were methodological flaws identified with the use of VAERS data to infer a correlation between sudden infant death syndrome and vaccination. Now, the minute you do that, you are absolutely on target. Now, here is what I think happened. There was another paper, which I said was published. This paper, they couldn't directly remove for whatever reason, but it critically cited that other paper in its documentation. This bit here suddenly makes this paper no longer stand up, because they have retracted a critical statement that this paper has done. Do you see what I mean?
Yeah.
Now, this, I'm going to come back to that in a minute, but you are touching on something here that people don't want to think about. And one of the concerns that I have is that asking these questions doesn't have to be a problem.
Yeah.
You know, meaning like when they ask about autism and vaccination, and there's this huge pushback, it's not. And I'm thinking, it's not a big deal, even if it was. You just say,
It's
here are the
responsible.
risk factors.
It's a responsibility.
It doesn't damage vaccines necessarily. If you can identify potentially children who are at risks based on their characteristics, so you would know there if they're low birth weight, exposure to smoking, so you know all of the characteristics of these children. If that is found to be relevant, you just be more cautious. Why is that such a big deal?
I don't know what happened, but like blinders, okay? And it's such a sensitive thing. And I mean, let me just make it very clear. Vaccines, okay, as a physician, there's no question, okay, just for everybody out there. The safety of the risk of having a problem from the vaccine is not even close to the risk of having problems from the disease. Okay, so vaccines absolutely are helpful. Okay, absolutely. If you want to gamble with your life based on these odds, then it's not a good choice. Okay, so let me just say that again. The chances of dying from the disease itself or having bad complications is much higher than from the vaccine itself. So let's just get that out there. Vaccines are safe over the numbers. Okay. But there are side effects to vaccines. It happens less often. And so now what we're talking about, and Dr. Goldwater's paper is looking at the cases that did have problems. Okay, so that needs to be said. Where vaccine safety, I mean, measles, mumps, it is tragic what's happening, and we're gambling with our children's lives, and that's unacceptable too. Don't gamble with shitty odds. Sorry, bad odds. Sorry, I lost my train of thought there. What were you saying?
You were talking about the fact. So let me just be clear about something. I haven't asked you this before, but because I know my audience, I know what they are thinking is that a lot of people who follow what I say, because I've always asked different questions around COVID and the pandemic, and I think that we weren't careful enough with regards to COVID
Yeah,
vaccines in
yeah,
the pandemic. Now, what has happened is that because there's been such a strong determination to say there was no problem, it has
mm.
damaged critically
Oh,
the trust in all vaccines. And this is now where there's a
the
huge danger for the public. And so I thought that I would clarify that because I suspected that that was what you were saying. And the point
I
here
did.
is that when I talk about, or when you are making reference to childhood vaccine, so I'm not talking about the COVID pandemic here. I'm talking about the fact that we've got tried and tested vaccines for measles, for mumps, for rubella, etc., etc. And the issue becomes, why would you destroy the credibility of these products by not being willing to look at potential risks? And that
Yes.
is effectively, it's almost as if the narrative has to be the risks are so small that it is irrelevant. Why does that have to be a narrative? We
Yeah.
prescribe drugs all the time. We know their side effects. It doesn't mean you don't use it.
Um, Honesty is the best policy. Okay, it includes in public health, public medicine, but paternal, authoritarianism. We know better than you, and we're gonna quiet down on this information. We're gonna keep it quiet. Okay, that kind of behavior, that's what leads to big problems. Okay, the approach was wrong, and that led, in my opinion, to so many more problems. We need to be honest and upfront in medicine, and um, not try to hinder or mute information because people might get the wrong idea. It Life is not like that. We have to go through the ugly side of things too. So that paternalistic approach backfired, in my opinion, on minimizing the risks, minimizing the dangers. Um, and it's a very complicated thing, but in the end, it created so much, it divided the public and their confidence in medicine because they weren't honest. And so we're left with trying to repair that. And now, there's I've learned through an American subcommittee that's researching, investigating into what happened with the COVID vaccine. So there was many problems. Okay, it was not properly checked for safety. I mean, I was misled to believe that when the vaccines that would help, that were properly checked in some way. I mean, they rushed it through. I understand that it's not perfect, but there was no one at any point, like the manufacturers didn't test safety, like the proper, like at least do some checking, and the authorities that from the government side of it also dropped the ball. And I didn't know this, but that's what really happened. So there was a big failure, and there's a subcommittee being chaired by Senator Ron Johnson from Wisconsin, and it is fascinating. They're finally, someone's like saying, finally they're uncovering it, and they're calling the BS about what happened. How the tragic thing though is many people's careers, they did honest work, honest papers. They were just producing results, but it didn't coincide with the paternalistic approach, and so they were shut down. Like you said before, like they're treated as their careers are ruined because they were shut down. And so the tragic thing is, okay, so now science is no longer open debate. Like, where are we headed now if we can't just be honest?
Yeah,
It's
so
despicable, it's
this is
disgusting.
where it's coming right back to the question that you are doing with the SIDS research. You are touching on a nerve that, as I said, I think the minimum that needs to be done with this is to look carefully at it, because straight away, part of the reason why I wanted to talk to you is that once you mentioned myositis, inflammation in the muscles in the
Yeah,
diaphragm, I knew straight away that that could help to explain why a lot of people who have post-COVID kind of pathology could have ongoing shortness of breath and chest pain. Just diaphragmatic myositis. Listen, and so I knew that this was important. But it only comes when you allow yourself the opportunity to reflect on the science and the implications of the science. And so this is why now I'm exploring with you, okay, this can happen in terms of infants, which can cause sudden death. I have now learned the possibility that this can also happen in adults in theory, which could cause sudden death in their sleep. And therefore, and this could potentially explain the unexplainable, where there are a lot of people who have no respiratory disease who are struggling with breathing and chest problems.
Yeah, it's so nice to hear someone get it. He was open-minded. I gotta say, like, I'm a little emotional right now because I've worked so hard on this. And yes, it's really simple. It is well known that viruses and also the vaccines that emulate them can damage muscles. And unfortunately, in medicine, we looked at, where the site, for example, the deltoid, people have problems there. But that's not the only skeletal muscle, right? We talked about this before. There's other skeletal muscles, and that includes the respiratory muscles. There's also the heart, right? If we look at the side effects of vaccines, there was cardiomyopathies and myocarditis. So inflammation of the heart muscle, and that led to some deaths. But we seem to have forgotten in a blind spot, what about the respiratory pump muscles? Could they be prone to myositis as well? So my research has shown that we just en masse in medicine basically have a blind spot there, that the respiratory muscles are prone to damage by viruses and some vaccines in rare cases. And so that is, you said it right there, Philip, is that just to hear someone else say it, like it gives me validation, like that this is underexplored, completely underappreciated. I just want to say one more thing. The body has two vital pumps. We know all about one of them, the cardiac, the one that pumps the blood through the vessels. But what about the other one that pumps air into the lungs? So you said, when the diaphragm contracts, air enters the lungs. That's a pump. When a pump fails and there's not help around, death will happen very quickly. And there needs to be more research, absolutely, on failure of the respiratory pump muscle. So myositis, and that's very clear that it was missed, that myositis can affect the respiratory muscles too. And that puts together why there's SIDS-like deaths after vaccines. And as that paper that got retracted was most often between day 3 and day 7, I believe. That's when inflammation, the damage is the most at that point.
Well,
And
I'm going to pause you there because I highlighted something in the paper that was done by Dr. Goldwater that he said. And what he had said was a quote or the analysis from the paper that had been retracted. Okay. And as I said, I realized why this was shut down. And if you look carefully at this, this is now what he pointed out. When they looked at 2,600 infant deaths between 1990 and 2019 in VARS, 58% of them were within 3 days. 78% were within 7 days. Now, I didn't know this. And now what they have said is that it is inappropriate to use this VARS adverse event reporting system to make that analysis. Well, what I would say is please just find all of them. Whoever has access to this, please just look at all of the deaths and confirm what the numbers are in terms of time frames.
Yeah.
Now, further, taking it further, he also positioned this in a confidential report from a manufacturer. 62.7% of these deaths were within 3 days, 89.6% within 7 days, and 97% in 10 days. I mean, when I saw this, I was flabbergasted.
Yeah.
I literally thought to myself, you are not telling me the scientific community knows this and is not investigating it? What is that?
Yeah, and they like to rip into the VAERS database data collection and say, oh, it's not accurate, but you can't prove causation or association even. But look at it. The deaths, first of all, there's tons of reports of sudden deaths happening within hours of the first day after a vaccine. There's many of those. And all the parents out there who hear this, I got you. I will look out for you. And they get just dismissed. And so when you look at that, at the very least, a thinking human being without bias would say, maybe there's something in the vaccine that's causing the problem, right? That's just like no brainer. And so, but that paper now has been retracted. That's good evidence. I mean, all it's saying is simply most of the deaths occur between day 3 and day 7. Like, that's not bad. That's not bad research. That's not bad data. And so
So
we're
I think
obligated to look at it.
I think just in case somebody is watching this who is really upset about me raising this, let me explain something that I think is important. People call me anti-vaccine because I challenged what happened with COVID with the vaccine, and I'm explaining. I am just interested in reducing adverse outcomes for patients.
Yeah.
Just because I would tell a patient about bleeding risks with warfarin doesn't mean me anti-warfarin.
Excellent.
I just need to be better at selecting the patients who are at lowest risk. In the age of AI, and I would say this now to any vaccine advocate, in this context where we are now in 2026 with the power of AI, you can risk stratify each individual very easily. And all you have to do is identify the risk factors. We know what the risk factors are. They have got it all listed here in this document.
You're talking about risk stratification.
We know what the
SIDS
risk factors are. And so therefore, if you see a high risk patient, when you actually combine all of this, and they are scoring whatever, because if, say, for instance, a male who had developmental problems, prematurity, is higher parity, parent is smoking, had a recent infection, lots of poor sleep, not breastfeeding, this is a high risk patient. And so what you would then do is you may then make sure you space your vaccines. You don't give them all at once. You time them. You think about it. You make sure that they are settled. They don't have any concurrent infections before you do it. What in the world is wrong with risk stratification?
Yeah, it's infuriating, and I can't explain it, but that is where it's looking like that's where it should go. And there's other tools, by the way. Like my research says, you can also do blood tests for muscle breakdown proteins, and help identify during an acute episode which children would be at risk. So it's very slow. I just got to say, like, medical research and medicine and progress is incredibly painfully slow, as I've learned in my outreach efforts. I now know why. But that is what to aim for. Yes, risk stratification, which of the whole population can we identify which ones are the needle in the haystack, and warn the parents, if this happens, or then to come in and get the blood test, at the community even, and then pick them out and bring them into hospital. The other thing I want to say is that the part of the reason why the respiratory arrest has been missed. The question is why? How has it gone through all this time? It's because of the inadequacy of respiratory monitoring techniques. We're limited. Modern medicine is limited in how we can measure it, and it's complicated. But that's part of the problem. And home SIDS monitors as well. They don't capture it either easily. Okay, but they can be designed in different ways to improve that technology based on this new information. So, yeah, I want to keep it positive. I've been very harsh on the medical establishment, especially with like putting a blind eye to things, and trying to control the conversation instead of having brutal honesty. Right? That's how I started this conversation. It takes brutal honesty in science, especially in science, to to do proper science and reestablish the reputation of the people, because it's just big time backfire. I hope that the decision makers learn their lesson there. Just be honest. All right, so I could
So
go
let,
on
let
about
me
that one.
let, let me stretch your mind a little bit now, Dov. So let's just think about it a moment, because as I said, it's one thing with regards to SIDS. Now, I'm not a pediatrician. I don't have any contact with little ones, so I know that's outside of my realm. However, I want to explore the concept of diaphragmatic myositis being present across the population and carrying with it symptom and potentially longer term risk. When you
Mhm.
think about it, how can we identify
Mm.
the patients who may have diaphragmatic myositis, which could be causing them, as I said, the shortness of breath, the chest pain? Is this just blood tests? Is it patterns of symptoms? What could we
Mm.
look for?
Yes, you changed gears on me there. That's good, and I have a chart on that, and I have to review it. But children are I'm familiar. I'm a ER doctor. I've seen many children, and it is well known that when they're just young children, when they're in distress, sometimes it's not obvious, and that's scary, right? Because things can happen very quickly. Arrests, cardiopulmonary arrests. However, there are ways. Okay, there are ways to identify from home, and using the risk stratification tool that Philip, you mentioned, that can be used easily just based on like data. Is there anything recent? Have they had a cold recently? That's a big one. Okay, a viral infection or a vaccine recently. Are they dehydrated? Are they breathing hard? There's some common sense things that we can educate and empower the parents to say, there's something off here. This child, something's wrong, out of the ordinary. There's more here, but to trigger the parents to say, okay, time to see a doctor about this. And then the doctor needs to, and they need to be prepared, okay, for what's going to happen in this situation. The worst part is this happens during flu season and RSV season, which is one of the viruses. So the ERs notoriously get inundated during this time. It's very hard for the emergency physicians to sort out the needle in the haystack. It's a very tough issue that happens year after year, and every ER gets overwhelmed. But in the future, when the parents come in, just get the CK blood test. Like I said, now we're talking about babies here, okay? Um, but but a simple blood test can look at the muscle breakdown protein, CK, creatine kinase. It's really simple blood test. And if it's elevated, like significantly elevated, you know that some muscle breakdown is happening in that child needs to be admitted to the hospital. If it's negative or low, then you can send home, or you can put in intermediate category. But triaging these ones, what do we do as far as in the emergency room? And then which ones to admit. So that makes it a lot easier, because right now it just like, who do you admit? How do you know which of these babies to admit? It's hard to sort it out. And then there's the new monitoring techniques that can be used. And at home, there's nothing like it yet. And gets complicated. And I'm sure there's gonna be a lot of people very interested to learn about this. Um, but it's complicated. Okay, to how do you monitor this at home? How do you monitor this in the hospital? Because it's being missed right now. The technology that's being used is not capturing it. But getting back to your questions, like enabling the parents. One more thing, just on that, every brand new parent needs to be taught about CPR on their baby. And I don't know if that's being done, to be honest. What to do if that child stops breathing? Like this is how these, like, there's so many reports. The parents put the baby for a quick sleep. They come back 10 minutes later and the baby's blue and not moving. Panic, sheer panic. And we need them to be prepared in that situation. Yes, call 911, but learning how to do proper CPR. And we're not doing chest compressions here. This is a respiratory emergency, and it's not so easy. Mouth to mouth. Okay, no, but it's not so simple in a baby. but we need to educate the parents on how to handle it. Yes, it's mouth to mouth. Yes, it's opening the airway so you're not, the baby, it can block easier. But if we can get the parents to deliver air right away, we will have a higher survival rate right off the bat. Um, so yeah, there's a lot of ways to go in this, and I like the tone of this of bringing it more positive, and to see where in the future AI absolutely it is absolutely going to be helpful in that.
I actually am pushing you even further than where you're going, Dov. I
Okay.
want to know how we find this in adults.
Yeah. Because so the reason why I said CK in babies, because like babies aren't running around playing,
Yeah, yeah,
so
true. Yeah, yeah, yeah.
so
But
that's where
I
the CK
understand.
level reflects. Yep.
But the
But yeah.
people that I am thinking about, because I'm already processing it in my mind and I'm just thinking
Mm,
about it. Okay, they've got shortness of breath, they're getting chest pain, all their tests have come back normal. They haven't got a
mm.
PE, they haven't got
And they
myocarditis, they're still struggling with their symptoms.
the
How
CK
can
level wasn't
I
done.
know whether or not this is diaphragmatic disease inflammation? That's the bit that I'm now
Yeah.
thinking
It-
about.
yeah. It's harder, but you could still do a CK level on them. Okay. I mean, as long CK can be elevated. It's not specific to the respiratory muscles. It's muscles of the whole body, right? So skeletal muscles. So as long as there's like no explanation of what else could be causing it, have they been working out lately or went on a jog or whatever, you can still use the CK level and follow it over time, the trend over time. Um, in fact, if they get worse breathing, then you follow the CK level, see what's happening. It may go together. There are ways absolutely to monitor this in adults. Okay, absolutely. I mean, at the bedside, it's obvious that when somebody's having more breathing issues to non-doctors, it's obvious. But there is the technology, electromyography of the diaphragm, ultrasound of the diaphragm, MRI of the diaphragm. uh, MRI is probably the best to identify damage in a live person. Muscles, evidence, like hard evidence of muscle damage. So CK is an indicator of it, the lab test, but the MRI shows it. So yes, this can all be done. It's the same monitoring techniques. You can also monitoring carbon dioxide levels. That's a sign of like respiratory failure from the pump muscles. This carbon dioxide level slowly increases. Just quickly, that's why patient zero, was gasping in the beginning. Remember, I said his mouth was opening like a fish out of water? It's called the gasping reflex. I didn't know about this before, that his oxygen level had dropped slowly during sleep. And the question was, well, what caused that? More complicated, but it got to a critical level, and that's what woke him up. The mouth opened on its own to gasp, and it was because something had caused a drop in his oxygen level.
Now, we've gone over an hour. This has been a fascinating discussion, and so
Mhm.
I want to close out now, Dov, and
I'm
I
tired.
want to think about, when you think about this research and what you have done with it, and this is now giving that vision of what would you want to happen if you got access to, say, Senator Kennedy, or whoever who thought, this is really important. What would you want them to do with this research, and where would you want it to go to fulfill its full potential?
Yeah, like I said before, thank you. Uh, Progress is very slow in medicine, but the magnitude of what I've uncovered is massive. We just talked about a fraction of it. It really needs an institutional approach. This is way more than a single person. Robert F. Kennedy Jr. is in that position. Because he's NIH, National Institute of Health in the United States. This thing needs to be explored from multiple angles, but at the very least, the simplistic one, just if it was start simple, is when I was speaking about that flu season, RSV season, how can we? That's where the study can be done. Let's just do creatine kinase levels in all children coming in of all ages for respiratory issues, and have a look and see, do they correlate to respiratory events? Does it predict um, more morbidity and mortality? There's so many ways to go with it. That's the simplest way. It's just a basic lab test. So that's where you can start. But as far as like the angle of the other thing that's really painful is that looking at autopsies. One of the things I uncovered, unfortunately, is that part of the blind spot here is because diaphragm histology. Now, looking under the microscope, the diaphragm at autopsy looks normal to the gross, to the naked eye. And there's plenty of papers though showing that microscopically or in histology there is damage there. Unfortunately, the guidelines right now for most pathologists do not include diaphragm histology, so the evidence is being missed. It's there. I could quote the papers on it. It starts with Carrick's 1989. So, just collecting data at autopsy, how many, how much diaphragm damage occurs, what kind of deaths does it occur? It is such a hard question to answer, Philip. It is massive, and I don't want to make it too complicated. But the other thing is, how do we identify diaphragm spasms and cramps? That's another important one, and it's very hard to measure. But electromyography, and that's fraught with a lot of artifact, and it's hard to do correctly. But I think now with this new knowledge, it's like they were getting noise signals. They couldn't identify what was causing these signals. They didn't know what it was, but they weren't looking at the diaphragm. They didn't realize that the diaphragm, when it's in spasm, is probably causing that noise, which they think is artifact, but in fact it's coming from the diaphragm, and that can be done very easily. It's the hard part. It's like an ECG with leads on the chest, but it's leads just a little lower over the diaphragm, and and uh, to relook at that information, clean it up, and I think there's going to be room in the future there to use EMG as the monitoring ability. I'm tired. I lost my train of thought a little bit there.
Yeah, no, no, excellent, excellent.
Mhm.
I just wanted to thank you, Dov, because you came on here at relatively short notice. I know that even talking about this was not necessarily the easiest thing, but I really appreciate the time to share this kind of knowledge. And what I hope for, because the truth is that it's a topic that not many people think about, and it's only largely relevant to parents of little babies. Beyond
Mhm.
1 year old, they probably won't think about it. But my instinct is that you have just opened a door to understanding a piece of symptom management that has gone under the radar. And I'm definitely going to be looking in more detail at this from a post-viral because I know I can instinctively feel this is really, really important. And the other one is to do with sudden deaths in the sleep. I really think if somebody has not had cardiac disease, if you're then going to think, if it is going to be something, it's less likely to be an arrhythmia unless you find clear evidence they've got something on their
Mhm.
heart, maybe a hypertrophic heart. That's different. But if they have a normal heart and they have no family history, then that could strongly suggest this is something else. So I'm going to be running with that concept. I'll
Thank you.
certainly make reference to you
Okay.
for it. So thank you very much again, Dov,
Oh, I want
and
to
I'll
may I
ask.
point out? I just want to may I
Yeah.
say something here is important. How to prevent this? Like practical advice to people who are listening to this right now. How can you prevent this? If you have a loved one and they're very sick and close to death, tell them, like, should you feel yourself waking up in a pain you've never felt before, like a cramp in your muscles, but feels like someone picked you up in a bear hug or something similar, go against the grain, breathe, and you can, assuming if they can't breathe in and they know they're about to die, breathe out to breathe in. That's what patient zero did, and it saved him. That's number one. That's the best advice. There's no harm in dispensing that advice. Number two is with all ages, as I said, sleep is the highest risk period. So those at risk with weak muscles or during a cold or dehydration is to another interesting thing is we don't give fluids to our young before bed because we want to do potty training. The thing is, give them fluids before bed because the dehydration, reversing the dehydration can prevent this. Give anti-inflammatories for fever, even if the child doesn't look well. If they're in pain or there's anything unusual, it's okay to give a little bit of Tylenol or ibuprofen. Okay, these things can help reduce the risk. I know I don't have evidence for it. Okay, but it's just common sense. And we're talking about lives here, so I don't need the evidence. Like I would love to have it. We don't have it right now. We want to prevent deaths. So what else can we do? Thumb sucking is fine. In fact, it helps. It's SIDS preventative. Pacifiers or sookies, which I learned the Brits call it, are SIDS preventative. So yeah, there's measures we can do to enable people to do something rather than feel powerless.
Excellent, excellent, excellent. So again, thank you very much. I appreciate the
Well,
people
thank
who
you.
have been with us
Thank
all
you.
this time. And if you just stay with me until after, and I'll just do this outro so that we can quickly chat. Thank you, everyone, for being with us, and have a great evening.